Dear colleagues, welcome to today's ESPN ERKNet webinar. My name is Max Liebauer. I'm a pediatric nephrologist from the University Hospital of Cologne in Germany. And it's my great pleasure to introduce today's speaker, Bert Bammens from KU in Leuven in Belgium. Bert is an MD PhD at the KU in Leuven. He is a full-time senior academic staff member of the Department of Nephrology, Dialysis and Renal Transplantation, and a part-time professor at the Nephrology and Renal Transplantation Research Group in Leuven in Belgium, with a scientific point of interest in cystic kidney diseases. And in Leuven, there's the specialty that adult and pediatric nephrology are closely working together. There's close collaboration of Bert with Jalila Mekali from pediatric nephrology in Leuven. And Bert is going to give the talk about ADPKD today. Bert, we're looking forward.
Thank you, Max. Thank you all to be here this afternoon. I see that there is a lot of attendees, so I'm very happy that everyone found the time to be here together in this virtual, so to speak, living room. And in the coziness of this living room, we will have this chat on ADPKD. My task will be indeed to talk to you about ADPKD, and I cannot proceed the slides. Yes, it works now. What I intend to do is take you through a little history of the disease, and I will start off with the things that are commonly known about the disease. Of course, ADPKD, autosomal dominant polycystic kidney disease, is pretty well known as an autosomal dominant disease, which of course means that every child of an affected adult has a 50% chance of having inherited the disease. It is also pretty well known that it occurs in 1 out of 400 to 1 out of 1,000 live births, and that it is characterized by a progressive cystic deformation and growth of the kidneys. And what we also know is that this growth of the kidneys is accompanied by a loss of kidney function. And although there is probably some difference, so probably this curve is not the correct one. I think there is diversity in the way the kidney function declines. There is more evidence today that it is a more linear decline over the age spectrum, but there is this common knowledge that increasing kidney volume is accompanied by decreasing kidney function, and this has even led to the acceptance by the FDA of the kidney volume as a surrogate endpoint in trials and studies with ADPKD patients. What we know is that taking the PKD group as a whole, the ADPKD group as a whole, that about 50% of patients reach end-stage renal disease by the age of 60, and also in Belgium, but also in Western Europe and throughout the world, 5 to 10% of patients reaching end-stage renal disease reach this stage due to polycystic kidney disease. So in the nephrology world, so to speak, ADPKD is a pretty well-known disease, particularly in the adult nephrology world. What we also know from a long time already is that ADPKD is characterized by some extrarenal manifestations. So besides the kidney phenotype, there may also be hepatic and pancreatic cysts, cardiac valvular abnormalities such as the mitral valve prolapse is a pretty well-known extrarenal manifestation. In some families, there is a higher proportion or a higher incidence of intracranial aneurysms, and some men with ADPKD have seminal vesicle cysts. We will not go into these details, but this makes a part of the phenotype of the disease. Some other extrarenal manifestations that are associated with ADPKD is the colonic diverticulosis. There is some discussion on this topic because it's based on, of course, observational data. And on the other hand, what we also know from ADPKD patients is that they have a tendency to have more abdominal wall hernias, inguinal hernias, etc. But again, I will not go into the extrarenal manifestations. We will be talking about the renal phenotype of the disease. Now, the disease has been known for a very long time, and there is even a report from the 16th century where a king whose name I cannot remember died, and during an autopsy it was found that his kidneys were not completely normal, and most probably, as it is interpreted today, were polycystic kidney diseases. First descriptive reports date back from pathology atlases, such as this one from Galeazzi, a Bolognian pathologist who made this picture of a polycystic kidney. And also later on, during the 18th and 19th century, there were more and more descriptions of the disease, but it was, as you know, just describing the disease, and there was not much known about the disease mechanism. Nevertheless, in 1888, Félix Léjard wrote in his PhD thesis that polycystic kidney disease would be treatable one day. And this brings me to one of the, of course, important reasons why we are so interested in this disease, and that is that we are desperately looking for a treatment, because these patients reaching end-stage renal disease and accumulating comorbidities as a consequence of the renal disease live not a very happy life. And so if we can improve this by treating the disease, this would of course be a great achievement. Having said this, even though the disease has been known for a very long time, till the second decade of the 21st century, so still today, I think the treatments we can offer our patients mostly focus on symptom control and control of the complications. And this is just a list from a review from a few years ago, but it still holds true that in our standard care for patients with ADPKD, we focus on blood pressure control because hypertension is one of the early symptoms of the disease. And we are convinced, as in all renal diseases, that treating hypertension is, of course, beneficial for the patient in general, for his cardiovascular outcome, but also for a kidney disease itself, for the progression of kidney disease. We focus on pain control if needed, because mast symptoms and pain symptoms may occur. We give antibiotics for urinary tract infections, and with progression of kidney disease, we try to prepare the patient for renal replacement therapies such as dialysis and renal transplantation. We also focus on general lifestyle approaches such as the maintenance of a healthy body weight, salt restriction as a way to improve blood pressure control, but also to lower intraglomerular pressure. And by doing so, we are convinced that we improve also renal prognosis, and we advise low protein intake when kidney function deteriorates, and we advise regular exercise. But as you can see from this summary, most of our therapeutic approaches to ADPKD are, let's say, aspecific and focusing on symptoms and on general renoprotective measures. This has tremendously changed, so to speak, over the last 2 decades, I would say, because we now have much more insights in the disease mechanisms, and this is where genetics comes in the game, because the identification of the exact genetic background of the disease, which dates back from the last decade of the previous century, the 90s, the identification of this genetic background has helped us a lot in improving our knowledge on the disease. And although these statements are pretty self-explaining, I wanted to use them as the first multiple choice question. Now, as you can see, it's very easy to answer this multiple choice question because most statements are true. There's just one that is not correct. And so I want you to, as a way to test also the system, to answer this. What is not correct? The identification of the genetic background has helped to better predict the renal prognosis of the disease, has paved the way for research into the many mechanisms of the disease, has been pivotal in moving treatment from only symptomatic to disease modifying, And now we are talking on the individual patient level, identification of the genetic background of the disease is possible in every individual patient. I predict that all of you will be able to find the incorrect statement, but I just want to see you participate in the poll. So Tanya, please, can you launch the question in the poll system? I'm not sure whether this works. Yes, it is working. Yes. There is a lot of voting. The voting is still going on. I think 75% of participants have voted, more or less.
Okay, I will close.
Maybe we can close the voting. Yes, thank you. And I think you can see now what the poll results are. I cannot see them on the slide, but I can see that not everyone has picked the right answer, because the right answer is the fourth one. And I will explain this to you in a few minutes, but today it's not yet possible to identify the genetic background in every single patient. But let me say that I'm a little bit surprised by the answers to the first and the third statement, because some of you think that this is not correct, and I'm convinced that all three statements are correct. I will try to explain this to you in the next few slides. First of all, let me tell you something about this genetic background. We know that I cannot proceed. Yes, it works. We know that most patients with ADPKD that are genotyped, we find a mutation in the PKD1 gene that was identified to be located on chromosome 16, as I said, in the 90s of the previous century. This is about 80% of cases are explained by PKD1 mutations. A smaller proportion of PKD patients have a mutation in the PKD2 gene, which is located on chromosome 4. These two genes code for two proteins. PKD1 gives rise to polycystin 1, which is a receptor-like large integral membrane glycoprotein, illustrated here. And polycystin 2 is a transmembrane calcium channel, which is illustrated here. And both channels interact with each other, and it is through their interaction that normal cell function occurs. And when this is disturbed as a consequence of a mutation in PKD1 or a PKD2 gene, this leads to a bunch of intracellular effects and leads to cyst formation, fluid secretion, kidney growth, and also inflammation and fibrosis, and eventually kidney function loss. Now, as one of the statements mentioned, the genetic background of the disease really does help to predict renal prognosis. It is one of the most important factors predicting renal prognosis. And this has been known for a longer time already. PKD1 mutations usually lead to a faster renal function decline than PKD2 mutations, but this is constantly being optimized. I mean, this knowledge is being optimized. And one of the important papers in this regard is the one by Cornec-Legal, published in 2013 from the group of Brest in France, where they showed that also the type of PKD1 mutation is determining the renal prognosis. And one of the most illustrative figures in pictures in the publication is this one. It shows the end-stage renal disease incidence in patients depending on their genetic background. And as you can see, PKD1, so-called truncating mutations, in that case, 50% of patients reach end-stage renal disease by the age of 55, while it is only 67 for patients with PKD1 non-truncating mutations, and even later, 79 in PKD2 mutations. And this is, as I mentioned, a view on the role of genetics in predicting renal prognosis, which is constantly being adjusted and optimized, because I'm aware of new data that show that even within the group of the non-truncating mutations, some differentiation is possible, and maybe we will be able to better and better predict the renal prognosis of patients based on the genetic background. Now, coming back to the fourth statement, which was the correct one, indeed, at this stage today, we are not yet able to identify the correct mutation, the effective mutation in every individual patient. We have patients with PKD1, we have with PKD2, but there is also a group of patients in whom the mutation using current technologies cannot yet be identified. This is about 5 to 7%. Having said this, there is a lot of work being done in science and also clinically to find mutations in these families. And some newer mutations that have been identified are in GANAP, that's one of them, or in DNA JB11. The most recent published one is ALG9, ERKNet, and again, I am aware of work being done covering the ALK8 mutations. So I think the spectrum of mutations giving rise to polycystic disease will become broader and broader. But having said this, according to current knowledge, these mutations all involved in the trafficking of the polycystin-1 protein to its correct location in the cell are account only for low percentages of the total population of ADPKD patients. They are usually also associated with a milder phenotype with a mix of hepatic and kidney cysts. So I think I have answered two of the statements, but the one that is really important for the future of ADPKD is the fact that knowing the genetic background of the disease has also given rise to a lot of investigations and studies in fundamental science using animals with selective knockouts of the PKD1 or the PKD2 gene, which of course has helped a lot in trying to understand the mechanisms of the disease. And this has led to a broad knowledge that is still evolving of intracellular processes that are involved in the development of polycystic kidney disease. This is an illustration that dates back from a few years already, and as I mentioned, it is constantly being updated by new findings. But as you can see in ADPKD, it was seen that some of the intracellular processes and pathways are upregulated while others are downregulated. The central finding in most studies so far is that intracellular cyclic AMP rises and intracellular cytosolic calcium levels are lower in ADPKD, and these two effects are often put in the center of the mechanism of the disease. But as I said, this is constantly evolving, and focus is changing maybe a little bit towards towards other pathways. We will learn more about this in the near future. I'm convinced that this will be the case. Now, having said this, knowing the mechanism of the disease, of course, opens the way to treatment of the disease, and not only symptomatic and complication treatment, but also to disease-modifying treatments. And this has of course been investigated in fundamental research in animal and cellular work, but it has already led also to clinical investigations and clinical applications. I will just focus on a few of these pathways. One of them is the mTOR pathway, which is, as you can see from this picture, upregulated or more active than normal in ADPKD patients. The mTOR pathway can, of course, be influenced pharmacologically by mTOR inhibitors, and this has been tested. These were the first clinical studies done in ADPKD with a disease-modifying purpose. and the mTOR inhibition has been tried, but I can just be very brief and tell you that this has not reached the clinical stage in a way that the clinical studies have not been able to show a positive effect, and side effects may play a role there as well. So this is not translated so far in clinical application of mTOR inhibition for ADPKD. The other pathway that is involved in the process is the somatostatin pathway, where somatostatin analogs theoretically could improve the processes intracellularly and lower or mitigate cyst growth and loss of kidney function. And again, these somatostatin analogs have been indeed used also in clinical trials. This is a summarizing slide from a presentation with studies dating from the first and second decade of this century. So it's not the most recent one, but this is the studies that gave rise also to the protocol that has now been published only recently from the group of Groningen, which I will show you in a minute. But what came out of these early studies with somatostatin analogs is that there is a potential improvement of kidney growth. As you can see, total kidney volume, cyst volume, parenchymal volume was improving was evolving in a positive way in terms of the treatment with somatostatin analogs reduces the speed of kidney growth, which you would expect, based on what I told you earlier, to improve or to result also in improvement of the loss of GFR. But in these early trials, this was an effect that was not seen. But anyway, these trials were inspiring the authors from Groningen, who developed and who performed this randomized study, the DPEC-1 study, that has been published only recently, and which studied the use of lanreotide, one of these somatostatin analogs that had shown in hepatic polycystic disease that the impact on the hepatic volume was clear and positive. So they studied lanreotide in a randomized fashion, compared it with standard care in patients with a kidney dysfunction of GFR between 30 and 60 mils per minute. And as you can see from this figure here, from this picture, there was this expected impact on kidney volume. In the lanreotide group, there was a lower percentage of annual increase in total kidney volume as compared to the control group. But again, against the expectations, there was no impact during this 2.5-year trial on the slope of eGFR, and there was no difference in after treatment eGFR between the intervention and the control group. And the authors of the study conclude that that although this impact on kidney volume was clear, the impact on eGFR was absent, and that so far in this population with moderately advanced kidney dysfunction, the use of a somatostatin analog for ADPKD is not advised. Now, this brings me to another pathway that led to clinical applications of drugs, and that is the vasopressin pathway. Another finding coming from the basic research is that vasopressin is most often increased in patients with ADPKD, and that the pathway is also more active. And this is one of the pathways giving rise to the higher cyclic AMP in the cells of these patients, leading to the processes that lead to cyst formation, growth, secretion, etc., etc. And so from this background, it makes, of course, sense to try and lower the activity of the vasopressin pathway. Now, one of the ways to do this, just from normal physiology, is by drinking a lot of water, because water intake would of course lower your own or the patient's own vasopressin production, and in a way, by doing so, could indeed inhibit the activation of this pathway. So that's also why many investigators have asked themselves the question, what about high water intake? And again, animal models have shown that high water intake in ADPKD models indeed can lead to lower cyst growth and lower kidney growth. The human models so far have not clearly confirmed this. This is just a sum up of a few studies that were done in, as you can see, small numbers of patients, and each of them have shown some effects of water intake on urinary osmolality, as you would expect, and on cyclic AMP excretion in the urine as a surrogate for cyclic AMP production due to vasopressin stimulation. But unfortunately, none of these small studies was able to show an impact on the renal outcomes, such as a kidney volume and renal function. In one of them, there was even, although non-significant, an opposite effect. This is the slide that shows the impact of high water intake in some animal models, where you can indeed see that high water intake resulted in lower cyst formation and smaller kidney volumes in a rat model, in a mouse model. But again, in humans, we are not sure yet. From evidence we cannot conclude today that high water intake is really a disease-modifying effect. This is still being studied in a well-designed randomized study that should show its results, I think, in the next coming months or year. This is a randomized study where usual water intake is compared to high water intake, which of course will need in the trial a lot of checks and balances to make sure that this randomization is well performed. But still, I'm looking forward to these results. I have not found the results published yet, so I hope that they will be able to help us and tell whether the natural suppression of vasopressin is helpful in treating the patients with ADPKD. Now I come back to the slide I showed earlier, where I sort of hid these two things here, because already for a very long time we advise our patients to drink a lot of water and also to avoid caffeine, for instance. And both of these interventions can be considered as general lifestyle measures, but on the other hand, they may, based on the background I showed you just a few minutes ago, they may also be or have disease modifying impact. The high water intake indeed will suppress vasopressin production, and so probably also the vasopressin pathway. And the avoidance of caffeine may also help to raise the activity or to maintain the activity of the phosphodiesterases, and by doing this remove or metabolize the cyclic AMP at the faster rate in the cells. So both of these interventions that are considered to be lifestyle approaches may also be disease modifying approaches. But again, we still need the evidence in the human studies. Having said this, we can of course also pharmacologically inhibit the vasopressin pathway, and this is what is being done when you use Tolvaptan. Tolvaptan is one of these vaptans, one of these vasopressin antagonists that are that have been investigated in terms of their potential effect on kidney growth and kidney function. And as you can appreciate from this slide, in a study that was performed a few years ago, a randomized trial, placebo-controlled, Tolvaptan did indeed impact on the slope of kidney volume growth and on the slope of kidney function in a group of patients between 18 and 50 years of age, and with a creatinine clearance of more than 60 at the start of the study, and a kidney volume of more than 750 milliliters. This impact is statistically clear and sound, although you you may argue that the clinical impact is potentially not extremely high, but there is an impact, and this study is a positive one, and the first one showing a disease-modifying effect of a drug in ADPKD. This impact was seen in all stages of kidney dysfunction in this trial, which goes down to CKD stage 3, because CKD 4 and 5 patients were not represented due to the inclusion criteria of the trial. But after this first trial, there was a second one, the so-called reprise trial, where the same drug was used in patients with lower eGFR at start of treatment. And after 1 year of treatment, it was clear that there is a positive impact on the eGFR decline for the treated patients, and also the slope of the eGFR declining curve was slower in the treated patients as compared to the placebo-treated patients. Both studies have really helped in order to get FDA approval for the drug. The first study sufficed, in fact, for the European Medical Agency to approve the drug. And since then, this is 2016, the drug is available on the European market for treatment of patients with ADPKD. I should mention, of course, that this drug comes with side effects, and one of the most important, or the most important side effect in clinical practice is the aquaretic effect. Of course, vasopressin inhibition leads to aquaresis, and all patients, and I know many of them now, all report that they have polyuria, and as a second effect there, they are thirsty, and so they drink a lot, and this may go up to 6 to 10 liters even per day. So this cannot be neglected, of course, but many of them, about 80% of these patients, manage this and keep continuing the treatment and are very positive about it. Another important thing that needs to be mentioned is that in the trials, in the clinical trials, in a very small percentage of patients, but more in the treated than in the placebo group, there were elevations of liver function tests. And that's the reason why EMEA and also FDA have made it mandatory, in fact, to have liver tests checked every month for the first 18 months of treatment in these patients, and afterwards every 3 months. Another issue in this treatment, as in all medical interventions we do, of course, is cost. And based on these 3 important factors, it is important for us as clinicians, of course, to select the right patients for this treatment. And this means to select the patients that will benefit most from this treatment. And to do so, I think we need to adhere to the inclusion criteria of the published trials. And these inclusion criteria were very clear in a way that they tried to select those patients with the most progressive forms of the disease. Now, having said this, you would expect, maybe from what I told you already, that selection for the trials would have been based on the genotype of the patients, given the notion that genotype does influence renal progression and prognosis. But this was not the case. In the trials, not all patients were genotyped. Post hoc analysis did show this impact indeed, but in the trials, the estimation of progression of the disease was based on the kidney volume. And as I mentioned in the beginning of the talk, kidney volume indeed is one of these surrogate endpoints that can be used as an indicator of progression of the disease. So also in this working guidelines from ERBP, this kidney volume and the category in which the patient would be categorized based on kidney volume, height adjusted kidney volume, is taken into account. And just to mention, in adult nephrology, it is not very difficult to measure kidney volumes, but we do need, especially for the large kidneys, we do need CT or MRI to evaluate, to estimate kidney volume based on the published formulas by the group from the Mayo Clinic, we are able to pretty easily measure kidney volumes of estimate kidney volumes, and based on these estimations also categorize the patients based on the publication by Razabal into progression classes. And in order to select the right patients for the treatment, we need to select the patients from class 1C onward towards D or E. This is also translated into the reimbursement criteria in some countries, not in all countries, but I think fairly over Europe, we are all using the same selection criteria for these patients. So with this background, I can summarize this part of the talk by saying that till the second decade of the 21st century, we are still we are focusing on symptom and complications treatment, but from 2016 onward, we do have a disease-modifying treatment, and this is even more important, research is going on, and we are learning more and more, and we will have more disease-modifying treatments available in the future. And just to illustrate this, and again, without going into the details, in our center, in our department, we are currently participating in 3 trials using different approaches for the treatment of ADPKD. All of them have selected the fast progressing patients, as you can see from the inclusion criteria, but each of them is working, each of them is using a drug that is working in another pathway responsible for the progression of the disease with a different side effect profile. And I think that in the future, we will have much more options to treat these patients, and the quest is still open to find more treatment options. Just one more word on blood pressure control, because we have mentioned, or I have mentioned, blood pressure control as symptomatic treatment in the beginning of the talk, but I must say that most probably, and I think that also basic science will support this, that blood pressure control, particularly using RAS blockers, which is the preferred blood pressure treatment in ADPKD and in kidney disease in general, is most probably also a disease-modifying treatment. I will not go into the fundamental research details there, but I can show you the data from a clinical study that was published a few years ago, the HALT-PKD trial, in which patients with ADPKD were treated with antihypertensives and were targeted to be in one of 2 groups, the standard blood pressure group and the very low blood pressure group. And in this second group, so the low blood pressure group, there was a slower growth of the kidneys. Again, the kidney volume increased at a slower rate in these patients. This did not translate into an impact on the eGFR slope. It's a bit like the effect of the somatostatin analogs, as I mentioned before. But I think showing this picture highlights the importance of blood pressure control and the impact it can potentially have on kidney growth, and by doing so, potentially also on kidney prognosis. Having said this, it's also important, of course, to treat blood pressure in order to improve cardiovascular outcome of the patients, which is important as well. Now, till now, I have been talking about ADPKD and I've been showing studies in adults, but our pediatricians or pediatric colleagues have been very persuasive and also very instrumental to me and to us as adult nephrologists to highlight the importance of the ADPKD also in childhood. And why is this? I think there is 3 important reasons for me to highlight this also during this talk. And this viewpoint was summarized also in a publication from Stefanie de Rechter, one of the PhD students of Jalila Mekali in our center. It's entitled Unmet Needs and Challenges for Follow-up and Treatment of ADPKD Disease, the Pediatric Perspective. But I would be happy to add the pediatric and adult perspective, because we as adult nephrologists should be aware of the fact that this is a disease that is not an adult disease alone, because the adult onset ADPKD, which is the most frequent one and is the one that we are used to see as adult nephrologists, is in fact part of a spectrum of the disease with symptomatic disease presentation spanning over the entire age range. It's not only adults who develop symptoms of ADPKD. It's important to show you this picture from the publication by Stefanie de Rechter, which shows the entire ADPKD spectrum and which also shows you that, and although this is only 2 to 5% of the patients, but that in some patients ADPKD presents itself during childhood age. Some forms are embryonic and lethal. Some forms are called the so-called very early onset ADPKD forms and can be already discovered in utero through ultrasound. And some of them develop during childhood and become symptomatic during childhood. Now, in these cases, which of course are presented most often to the pediatric nephrologists, it is a very important step in the diagnosis and the workup to do genotyping, because many of these early forms of the disease are characterized by the heterozygosy for a PKD1 or a PKD2 mutation, but combined with other mutations, such as a hypomorphic mutation in the other allele or another cystic nephropathy genetic disturbance. So that's one of the important things to be mentioned. But again, as I told you just a minute ago, it's important to note that in this small percentage of patients, these patients are symptomatic. They may present, as mentioned, prenatally or in severe, very early onset forms, but they may also have more subtle symptoms, such as polyuria due to their concentration deficiency, nicturia, infections, hematuria, pain. About 20% of patients, based on observational data, have low-grade proteinuria, and which is in the meantime pretty well known, children with ADPKD develop hypertension in a substantial proportion of the patients. And so this is one thing that needs to be noted. Having said this, it's not the majority of the children with ADPKD that show symptoms during childhood age. So there is a lot of patients with no symptoms, but even if they are asymptomatic in childhood, as it is a genetic disease, it begins in utero. And at adult age, when we see the patients and when they become symptomatic, we must acknowledge that much harm in the kidneys has already taken place, because even if kidney function measured with a blood sample or an eGFR measurement is still normal, this is this is the result of hyperfiltration in the functional parenchyma. And so based on this background, it makes absolute sense to identify earlier biomarkers of disease progression and to do this in children with ADPKD. It makes also absolute sense to identify modifiable risk factors for progression and to do this in children, because this is the population where we can save a lot of tissue. And it makes, of course, also sense to search for early treatment options with acceptable side effect profiles. And although we are not there yet today, I think this will be the future, as it should be in all diseases with a genetic basis and with an early onset. So what helps for this, of course, is gathering information on patients. And Professor McCauley has started the ADPKD, the ADPedKD registry in collaboration with Max, our moderator, and Professor Schaefer from Heidelberg. And today there is already 83 centers participating in this prospective registry from 29 countries. It is a global initiative with a lot of centers globally and 725 patients included in the registry. And I'm convinced that this registry will learn us a lot, because it is well performed in a way that at inclusion, patient data, retrospective data are entered, and then prospective data are also entered at a regular basis. And this will, of course, gather and lead to a lot of information on the disease trajectory of these patients, and will also help to identify modifiable risk factors other than the ones we know already, and to identify biomarkers that predict disease progression and of course with the high potential of leading to treatment options in the future. Talking about modifiable risk factors, I think it's worth mentioning and showing you this publication from Marcella and colleagues from Italy, who based on data from European centers, so multi-center approach, in children using 24-hour ambulatory blood pressure monitoring, show that indeed even at childhood age and when the patients are asymptomatic still, that they may already have hypertension, that many of them have no nocturnal dipping, which you would expect, of course, in a healthy subject, and that some of them have only nocturnal hypertension. And this shows, although there is still there is no data clearly showing that treating this hypertension improves the prognosis of the patients, but I think from a logical viewpoint, from a physiological and pathophysiological viewpoint, it makes sense to treat, although as I mentioned, we don't have the evidence yet, but it indicates that focusing on blood pressure in children with ADPKD makes absolute sense. Focusing or talking about early treatment, I think we do not have clear evidence yet on early treatment. There is unclear and unconvincing data on statin use, for instance. Maybe we will see more on this in the future, but today I think we do not have medication, clear pharmacological interventions that are disease modifying. There is the trial with Tolvaptan in children that is currently, I think, still running in some centers, but coming to an end for a final analysis of the data. I'm looking forward to this because, of course, this is where we need to go, finding a treatment that intervenes early in the disease process. Finally, just 2 words or 3 words on another aspect of pediatric ADPKD follow-up and adult, I mean the whole spectrum is involved here, is the question on screening of at-risk children. Should we do it or not? I think today in 2020, this is still a controversial question, and that's also why I have put it in the second poll question just to finish the presentation. But now we are not talking about symptomatic patients. Now we are talking about asymptomatic children of adults with ADPKD, and the question whether we should screen them and at what age we should screen them. And screening then can have different meanings. You can have, of course, clinical screening, blood pressure measurement, kidney function measurement, imaging, and you can have genetic screening. This question, I think, is still partly open for debate, but I want just to raise this question to you and ask, knowing what you know now, given the current scientific knowledge and therapeutic armamentarium we have today for ADPKD, what do you think? Which of these 4 statements do you agree most? And they are not black or white statements. The first one is all at-risk minors should have clinical evaluation. The second one, all at-risk minors should have genetic evaluation. The third one is more nuanced. All parents of at-risk minors should be advised to comply with general health measures for all of their children, regardless of whether they know the child is affected or not. And the fourth one is all parents of at-risk minors should be advised to comply with general health measures for all their children, with particular focus on blood pressure control. And I have put asterisks there, which cannot be shown in the slide with the poll because it's too many characters. But I think, of course, that there is some particular situations where screening is the logical next step. But now we are talking about those patients that are asymptomatic. And for the ones that where no questions are asked, what should we advise these parents to do? And then I see that the poll is progressing and that so far there is answers in all categories. So this illustrates again that I think the opinions on this topic are still diverse. We are now at 67% of attendees having voted. And I think we may end the poll. As you can see from the results, about half of you, which is a majority, is in favor of the last statement. And I will admit this is also my viewpoint. But then again, there is about half of you, well, let's say 42% in total, that would advise either clinical or genetic evaluation of all at-risk minors. So this illustrates that the opinions are divergent or different, and this is today, 2020, but this is not completely new. Again, I want to refer to a publication that was done by Stefanie de Rechter during her PhD thesis in Jalila Mekali's group, polling also this type of questions to a large group of pediatricians and nephrologists and geneticists. And as you can see, this is just one of the results, and this is the result on testing. You can see at the least you can say is that there is different meanings on different topics, but that most practitioners are pretty much in the same area for each question. Although you can see that clinical testing for minors, there is a disagreement between the geneticists and the clinicians, that most of us are in agreement on the fact that we should clinically test at-risk adults, but for children, the agreement is somewhat less clear. And on genetic testing, there is a general, let's say, disagreement in terms of genetic testing by the agreement that the idea that we should not do it, or rather not do it, that's the correct phrasing, by adult nephrologists, pediatric nephrologists, but the geneticists have another meaning there. But again, of course, everyone looks at this question from his or her own perspective, and this may also explain part of the differences in attitudes and opinions. Having said this, I think that I should stop, and that I can conclude that there is a lot of things we know already on this disease, but there is still a lot of questions open, fundamental scientific questions, also clinical questions, also more like philosophical and ethical questions, and that there is still a lot of work to be done. And I think that this can be done because there is this lively collaboration between different disciplines, also in our own center. And at the end of this talk, I really want to thank Professor Mekali and our geneticists. Koen de Vriend is one of their representatives. Rudy Venneke is from the Fundamental Research Labs, for the lively collaboration we have. I think that the multidisciplinary approach in order to answer all the questions that still prevail is very fruitful and very important in this disease and in many other diseases. And I'd like to thank you for your attention.
All right, thank you, Bert, for a wonderful overview. Thank you very much indeed. I think we have time for a couple of questions, and I see the first questions coming in. There was one question, how do you monitor your patients on Tolvaptan? How frequently do you do total kidney volume, or how frequently do you in your center look at urine osmolality?
Okay, there's different aspects. So there is first of all the follow-up of the liver tests is mandatory during the first year and a half, every month. At every instance when we measure liver function tests, we do measure kidney function. So we do have slopes and curves of kidney function for all patients up till 1.5 years, and thereafter every 3 months. So that's a continuous input we have. there is no standard protocol of following up on the imaging, so the kidney volume is not standardly monitored. It's not mandatory for the treatment. It is, of course, interesting in terms of from a scientific point of view, but it's the kidney function that we follow up clearly. The kidney volume change will also not will have no impact on treatment adaptations, by the way. So that's also one of the reasons why it is not performed standardly. And in terms of the osmolality, we do monitor osmolality urine osmolality every 3 months in the regular follow-up, and we also use this urine osmolality just not to adapt doses, but in case a patient does not support a high dose and we need to lower the dose of tolvaptan because of clinical tolerance reasons, we check for urine osmolality because in one of the post hoc analysis of the Tempo 3/4 trial, it is clear that you see an effect of the treatment as soon as the urine osmolality is below 250. Now this, what I just said, is an overinterpretation of the data, of course, because the study was not intended to show this. It was a post hoc analysis, but we used the osmolality in the urine just to make sure, or to assure ourselves of the fact that the treatment is effective.
Right, and then I'm combining two questions. There is a question about unilateral involvement in ADPKD, whether you can have ADPKD with unilateral involvement, and then there is a question about the best antihypertensive drugs in ADPKD. Which ones are the ones you use?
Okay, well, the unilateral involvement, it is not impossible to see patients with unilateral involvement or with one kidney having more cysts than the other one. These are the so-called atypical forms of ADPKD. Again, in the publication which I referred to, the Irazabal paper, you can also find details on these different types of involvement by ADPKD. Having said this is the minority of cases, a small minority of cases. And if you ever happen to meet a patient or to see a patient with a unilateral polycystic kidney, it makes absolute sense to do the PKD genotyping. But if you are not able to find a PKD1 or a PKD2 mutation, it also makes sense to go that extra mile and do a gene panel or a genome-wide investigation for other genes involved in cystic kidney diseases. For instance, the GANAP mutation, DNA, JB11, ERKNet have all been described as mutations with lower numbers of cysts and also potentially unilateral involvement. So it makes sense to look for other genes if PKD1 and 2 are not involved, but it's not impossible. And then the second question on the antihypertensive treatment, the preferred treatment is RAS blockade. In the HALT-PKD study, for instance, there was I think it was lisinopril and valsartan that were used. This is an ACE inhibition, and the other one is a sartan. So it makes absolute sense again to use treatments that inhibit or that impact on the RAS pathway, because this is the ones that have been used in the published trials on the one hand, and secondly, it makes also sense to do so because of the mechanism of disease. The activated RAS system is also involved in the inflammation and in fibrotic process that leads to the progressive loss of kidney function in ADPKD.
All right, actually there are now a number of questions coming in. I'm afraid I think we will have to cut it down. I take one last question. Maybe I'm sure that that people can approach you directly via email and ask their most urgent ones. There was one question about polycystic liver disease and the role of polycystic liver disease during research, and what is the status of the studies on liver drugs?
Well, the disclaimer I will start with is that I am not involved in liver drug studies at the moment. What I am aware of, and what is also used in clinical practice pretty often in cases where livers are really very voluminous, is the somatostatin analogs. They have shown clear improvement of liver volume, and also improvement of the symptoms related to the volume of the liver. So that is the treatments that are currently being used in clinical practice for high liver volumes. I hope this partly answers the question.
All right. Thank you very much indeed again, Bert, for this very nice overview. And thanks to all the participants. And we're looking forward to seeing you, or to hearing all of you again for the next ERKNet webinar.
Which I may just need to show on the next slides. Thank you to all of you again, and thanks again also for the invitation to speak.
All right. Goodbye.
Bye-bye.
Bye.